Welcome to the presentation of part 3 of lecture Crystal Deposition Arthritis. How can we evaluate a patient with evidence of gout? At first, by doing serum studies, which include measurement of serum uric acid. Usually serum uric acid is elevated in about 90% of gouty patients. Measurement of serum creatinine, which may be elevated. This may reflect gout-related nephropathy or primary renal disease. Second, by doing urine studies to measure 24-hour urine excretion of uric acid, and if more than 800 milligram per 24 hour, this means that there is overproduction of uric acid. Regarding radiologic finding in gouty arthritis, usually there is soft tissue swelling around joints. Joint space is preserved till late in disease course. No periarticular osteoporosis. Erosions appear punched out with overhanging edge. This image shows the radiological finding in gouty arthritis in feet. The same finding: soft tissue swelling, joint space preserved, no periarticular osteoporosis, punched out erosions with overhanging edge. This image shows radiological finding in gouty arthritis in hands. Also, soft tissue swelling, joint space preserved, no periarticular osteoporosis with erosions which appear punched out with overhanging edges. Treatment of gout include: number 1, lifestyle modification with maintenance of ideal weight and exercise. Also, purine-restricted diet may be of benefit in some patients, but only small changes in uric acid can be attained. Low calories, low carbohydrate, and fat diet is more beneficial. Other factors are ingestion of at least 2 liters of fluid daily to prevent nephrolithiasis, together with avoidance of alcohol, low-dose aspirin, thiazide diuretic if possible. According to treat to target principle published in Anaromatic Disease 2017, chronic gout is treated as following. At first, our target is to restore serum uric acid level to below 6 mg per gl. And if there is severe gout with tophi or frequent attacks, the target must be below 5 mg per gl. The second step in treatment of gout is by drug therapy, by use of urate-lowering agents to prevent renal parenchymal damage, to prevent nephrolithiasis, and to suppress articular flare. But who will be treated with urate-lowering drugs? Patients with established diagnosis of gout plus equal or more than 2 attacks per year, gouty tophi, chronic kidney disease stage equal or more than 2, and patients with nephrolithiasis should receive urate-lowering drugs. During urate-lowering therapy, prophylactic colchicine in a dose 0.6 mg twice daily should begin 3 days before the initiation of therapy and continue at least more than 8 weeks. In general, when colchicine prophylaxis is used in this setting, it is continued for 6 to 9 months. In elderly and those with impaired kidney function, the dose is only 0.6 mg daily. In dialysis patients, oral colchicine is generally best avoided. The first group of urate-lowering drugs are uricosuric drugs, like propensid, but it is indicated when there is normal urate excretion, normal kidney function, in absence of gouty tophi, if there is no renal calculi, and the initial dose is 500 mg twice daily for 1 week, to be increased to 1 gram twice daily depending on serum urate response. The second group of urate-lowering drugs are xanthine oxidase inhibitor. The first one is allopurinol, which is indicated in almost all conditions. If there is hyperexcretion of urate, if there is history of renal calculi, presence of gouty tophi, even in presence of renal insufficiency, and before cytotoxic therapy for neoplasia, and after failure of colchicine prophylaxis and uricosuric drugs. Allopurinol is given in a small dose at first, 100 mg daily, and to be titrated or increased gradually according to kidney function to maintenance dose of 300 mg daily. Toxicity range from pruritus and dermatitis to severe allergic reactions with skin rash, vasculitis, and granulocytosis. Alternatives of allopurinol include febuxostate, which is better in renal impairment. It has no allergic side effects but may cause abdominal pain and diarrhea. The best effective dose of febuxostate is 80 mg per day. These, together with prevention of nephrolithiasis by either alkalinization of urine, by use of sodium or potassium citrate or acetazolamide, and by large volume urine at least 2 liters per day. Also, treatment of gouty patient include treatment of recurrent acute attacks, treatment of persisting chronic synovitis, which can be managed by local steroid injection, especially if monoarticular or oligoarticular disease. Surgical removal of large tophi is indicated if they are infected or interfere with joint function. Please look at these updates. Recent versus current therapeutic modalities of gout will be discussed in face-to-face session.